Hello, my name is Maxwell Bowen. Be talking about PIDs, STDs, all that jazz, all that fun stuff in general. First of all, STIs, they know no gender, class, racial, ethnic, or social barriers. All individuals are vulnerable to them. This poor girl that got admitted to the ER, she's young, she's been safe. I'm going to assume she's been safe, but she caught it. Now she has to deal with the repercussions. Because she's young, a diagnosis of an STI can be devastating to the woman and her family. Even to suggest a test for STIs can appear inappropriate or offensive. When a client must be screened for STIs, explaining the need carefully and not revealing to other family members that testing has occurred is quite essential. With the patient in question, privacy between her and her health providers must be maintained and emphasized. Otherwise, she may not seek out help again if she feels that her privacy has been breached or respect has not been maintained. This is bad, obviously, because, she catches another STD, has another PID episode, and she doesn't seek help again. Prevention of STIs, probably the most important thing, but unfortunately, our patient already has it, so we're just kind of focusing on how to handle it from here. Right now, she's having a discharge, vaginitis. It's like a generic term, between an inflammation and infection of the vagina. 100 causes, many different causes, but usually either done by Candida, fungus, Trichomonas, a protozoan, or Gardnerella, a bacterium, a very fancy name for a bacterium. The nurse's role in managing vaginitis, or really PID in this case, is really we're going to give her primary education on how to prevent it, how to deal with it, and really those two things, because we don't want her to get reinfected constantly, and we really don't want her to spread it around and cause a little domino effect. Primary prevention is going to begin with basically with women that are having constant VVC infections. We want them to reduce dietary intake, simple sugars and soda, wear white 100% cotton underpants, avoid tight pants or exercise clothes with spandex. We want to take showers instead of baths, don't let it sit there, stew, I guess. We want her to wash with a mild, unscented soap and dry the genitals gently. Avoid bubble baths. Once again, emphasize shower, no scented bath products. Wash underwear, in unscented laundry detergent, hot water. We want to dry underwear in a very hot dryer. It's going to kill that yeast that clings to the fabric. We want to remove wet bathing suits promptly. Practice good body hygiene. Avoid vaginal sprays, deodorants. Avoid pantyhose. Use white instead of toilet paper. Make sure front to back, not back to front. It's a common one, I guess. Avoid douching. Douching is bad. No one likes douches, so you shouldn't like douching. So it's a good way to remember it. And avoid the use of super absorbent tampons. Use pads instead. Let's talk about PID. PID. It's a common and serious reproductive health disorder in which states remain unacceptably high among adolescent girls and young adult women in the United States. Refers to an inflammatory state of the upper female genital tract and nearby structures, the fallopian tubes, the ovaries, the peritoneum, that word, may be involved, and endometriosis may also be present. PID results from ascending polymicrobial infection of the upper female reproductive tract, frequently caused by untreated chlamydia or gonorrhea. Annually in the United States, the CDC, as of 2015, estimates that more than 1 million women experience an episode of acute PID, and up to 10 to 15% may even become infertile. It's pretty scary stuff. This isn't about infertility though. It's a different subject. It's a serious health problem in the United States, costing about $10 billion. Hospitals and just care for these patients. That's $10 billion. Could be spent not treating STIs. Probably go to somewhere else. Maybe like educate the children. How we're going to treat it, really. Basically, broad spectrum antibiotic therapy. We don't know specifically what's causing it until it's been identified via gram stain, a culture test. So initially, we want to use botulinum antibiotic therapy. Some of the current things recommended, some of the more common things you'll see in the hospital is ceftriaxone, 250 milligrams, doxycycline, and metronidazole, that one, and cefoxitin. I'm so sorry, I don't know these words. It's uncommon in pregnancy, but if happens, you definitely need to get these antibiotics done because can cause complications with birth, mess up the baby. If you're having PID, vaginal issues while pregnant, you want to take care of that. Absolutely. Diagnosis, we think she has PAT. It's tentative. So some of the things that are going to support our diagnosis of PID with this patient is abnormal cervical or vaginal discharge. She has that. Oral temperature above 101. That's checked. Cervical motion tenderness. We're going to need to check that. Elevated erythrocyte sedimentation rate, which is basically an inflammatory process. Elevated C-reactant protein, once again, pointing towards inflammatory process. With the culture stains, we want to know if they have gonorrhea or C. trachomatis. With the smear, we don't want to see white blood cells, otherwise that shows, hey, they're fighting infection in your vagina. Dysmenorrhea, dysuria, acute lower abdominal pain, painful sexual intercourse. Hopefully she's not having sexual intercourse while having discharge and all this stuff. And nausea and vomiting. And her nausea and vomiting is so bad she hasn't eaten, so this is going to cause other issues. So that's pretty terrible, especially her not drinking water. So with her, we really want to maintain hydration via intravenous fluids if necessary and administer analgesics as needed for pain. Once we get her rehydrated, flowing, she's going to flush all that stuff out. Once we give her something for her pain, it can lower the inflammation, and she'll be able to eat again. We want to, once we have her in the facility, we want to put her now in a semi-Fowler's position, so she's going to, drain on out naturally drain. And then once we have her treated, the big thing we want to do is prevent recurrence. Depending on the hospital setting, and in this one, I'm so sorry, I'm so slow. Basically, we need to ascertain the patient's, their type of personality, their understanding of safe sex, STI, STD prevention, and take it from there, because if we assume the patient's knowledge, we're only going to end up having things fall through the cracks of like, oh, I thought condoms you unfurl them before you put on. No, that's not what happens. This is why you're catching these things. So we do want to catch that. And also, if they have a partner, we don't know if she has a partner, it would be very helpful to include them in the treatment. Some of the lab tests we can do to check out the etiology of PID is we can check liver enzymes, that can rule out hepatitis, pancreatitis, cholestasis. We can do CBC, which is basically elevated red blood cells and hematocrit, which our patient is probably dehydrated with how much they're vomiting, urine ketones, which probably is happening with her, TSH, T4, we can rule out thyroid disease, blood urea nitrogen, urine specific gravity, serum electrolytes, and ultrasounds. In certain cases, once the PID progresses to a certain state, we're going to push for hospitalization. That's what I got. And I will get critiqued for this and do better next week.